introduction and turn it over to Dr. Deb real quick, because we're late for the East Coast people, but I appreciate everybody who is here, and I'm sure we'll have some more jump on. So I helped Dr. Toracca get started with our first PA's wave probably 3.5 years ago now. Is it that long ago?
I think so.
And since then, she's become a true supporter of Elevation and the linear therapy source, and just we really worked through some different protocols and experimented with different things, and kind of working beyond just our traditional joints and making sure we look at the whole dog. So she was going to kind of answer questions, talk to you about what she's done with the stifle. The one thing I want to bring into before we start is that you guys all have seen my magic book that describes the simplest way to treat things. So don't get stuck on that, okay? There is 100 ways to do things. Nothing is right or wrong with the piezo wave as long as you and your brain have a why. So, you know, I don't want you to say, well, the book said do it from one place, or Dr. Owen says this, or so-and-so says this. Let's understand that we're evolving, and we should all be really open-minded. And Dr. Deb and I have been doing some of the CCAT labs and learning from each other, and I hope you guys can learn from her. So it's all yours.
Thank you so much, Cindy. And I apologize. So this is not my dog, but we're preparing for a manual therapy 3-day course tomorrow. So all the elves in my clinic are cleaning and all of that sort of stuff. And the dogs are locked in an office with me. So this little guy is hiding from the vacuum cleaner right now. But so we definitely see a ton of stifles. We kind of run the gamut. I think COVID has definitely pushed us seeing more and more conservative cruciates. During the height of COVID, we just, you know, there were animals that couldn't get in for surgery, so they wound up in rehab, and we found that a lot of them, I would say at least 50%, did well enough that they did not need to go into surgery. So that was, you know, very interesting to look at. And whenever we look at success, we have our objective measurements here. We have dynamic gait analysis, the WellView thermal imaging, all of the hands-on sort of stuff. Of course, also with the owners, like we always ask, what are the owners, kind of what looks like success for them. So a dog that needed to run agility, or one of the police dogs, that would be a little bit different. But for a good, like I said, at least 50% of them did not need to do surgery. And utilizing the piezo wave was a huge component with that. And I've found just through a couple big things, through talking to other practitioners and teaching with Cindy and without, is that so often we're not getting the real uncomfortable areas of the stifle. Like, so I always tell my staff, let's start on the medial aspect, because everyone just goes laterally, and sometimes they'll just hang out there and never move. If we start medially, where there is a lot of discomfort and we have the bony changes occurring and all of that, where, you know, I spend probably 1/3 of the time on that area. Then the other area is the distal hamstrings, because there's so much compensation going on there with, you know, trying to stabilize that stifle and help with that. So I'll spend another 1/3 of the time there, and then the remainder on the lateral and the patella area. The other thing that I've noticed is people use way too much energy. Like, and I teach with all guys, and Cindy knows I give them a hard time and I love them. But one day I walked into the lab and they were trying to hurt each other by, like, you know, turning up the machine as high as it goes. And I found that lower levels I'm more successful with, you know, sticking at 0.5, sometimes up to 2.0, but I really never go beyond that. Many people seem surprised by that, but I find that I get the changes I need. We'll typically dynamically force plate them prior to and then after shockwave. And then we begin our manual therapies, like especially massage to the distal hamstrings, and then our other manual work. So cute.
He's so cute.
And he's not even my dog. He just needs some attention there. So, and with, you look at the dogs energy. Jennifer, if you can just turn your thing off there. We're getting an echo. Okay. But it, and again, looking at the multimodal approach and working with the unit and starting to work on then strengthening balance and proprioception, starting to get them back, to normal. That's conservative cruciates, but also on the TPLOs and TTAs, and we see a handful of extracapsular repairs, working on that, kind of a same principle. So again, the medial stifle is often a painful area, working on those distal hamstrings. And we'll start pretty soon. We will see the patients typically 10 to 14 days post-op, and we'll use photobiomodulation over the wound and if there's edema, but then we'll start, using the piezo wave to try to get blood flow, to get healing. If we have the TPLO or the TTA where we want to get healing occurring there and starting to get all of that going. One of the other things that we always do is treat the contralateral stifle. So owners know we come in and it's built into the program. We charge by time in our clinic, not by modality or how many times we'll use the shockwave on different joints, unless they're coming in just for that. So we'll treat the other stifle all the time, whether it's a surgical or conservative. We know that the statistics look at 40 to 60% of dogs are going to tear the contralateral ligament. So I always find that is so important, with the whole perspective there of things. So far, does that make sense? Does anyone have any questions with that? Maybe easier to raise hands, and I'm trying to.
I have a question.
Okay.
So I recently was asked about using the shockwave in treating a torn ACL that the people do not want to do surgery on.
Yep.
But I really think that this dog needs surgery.
Mm-hmm.
So I have a hard time saying okay, yes, we can use shockwave. And
Sure.
Where I'm in Iowa and I've been charging $100 a treatment. And I just have a hard time being okay, we can try this without them thinking that it's going to be a magical cure. Sure. Or it doesn't work. And then they're blah, 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 this should have worked kind of thing.
Yeah.
So, and to me, where we live, TPLOs cost, $3,000, super relatively cheap in the Midwest. Oh, yeah. So it's if we're going to shockwave this thing 6 times,
yep,
I would rather you take that $600 and put it towards a surgery. But I guess I just don't know if you can give a little bit more insight into using it on a surgical leg.
Definitely.
And the dog is active. They aren't really exercise restricting it at all. And they thought hydrotherapy was going to cure it, and that obviously didn't.
Right.
And, so I'm the people are a little bit unrealistic in their expectations, but yeah. I guess, do you have any insight on using it in a non-surgical leg? How, you know, what's the timeline like, the frequency of treatment and that kind of thing?
Yeah, no, definitely, because, you know, we do, you know, I hear it every day that owners want to avoid surgery. And like I always say, if there's a meniscal tear, that's a deal breaker, like you have to go. But I'm very clear with the instructions that we'll take the treatments in 2-week increments. So we'll treat once to twice a week, depending upon the owner's schedule. And we'll reevaluate every 2 weeks. So looking at, are we making improvement? Are we the same? Are we worse? With the understanding that if we are worse, then, you know, this is not working. If we're status quo, like certainly examine what they're doing at home. So I'm very strict with, you know, what we do here is important, but what the owners do at home is more important, because you could have the best chance of helping the dog, but they're playing ball in their hallway, you know, obsessively, and we're getting nowhere. So I stick with just leash walking, try to minimize any running and stopping, you know, with that it is a dog, and, you know, maybe, you know, they're going to do things, you know, every once in a while. No ball playing, no jumping down off of furniture, within reason. So, you know, like really trying to alter their lifestyle and put forth an effort. And in the same token, they're doing leash walks. I do have them do some balance, weight shifting, like forelimbs up on an unstable surface and looking up and to the opposite side of the affected leg. So if it was a right partially torn cruciate, have them look up to the left. And this way we're transferring more weight, activating the hamstrings. So they do get strict homework at home, and we take it in, you know, small increments. So every 2 weeks, and, you know, re-examine. And certainly, you know, you weigh out the cost, and, you know, there's all these different reasons that owners don't want to do surgery. So, you know, like I was dealing with 2 of them today, but they want them to go back to doggy daycare. And I'm like, okay, that's nothing but running and stopping. And so if that's what you want, then I would suggest surgery or alter your dog's lifestyle. But it is, you know, tough. And I've had dogs do incredibly well, and the owners think, okay, we've been doing this now, like the dog's great, we're walking them 45 minutes, and they go back to playing ball or fetch or something. And, you know, I really try to give them the visual that cruciate may be hanging on by a string until scar tissue, like we're never going to repair it. So, you know, working, you know, with that. But it is, you know, it takes, to me, like they sometimes they don't want to do the rehab after, or they feel bad, but I'm like, a lot of times, like the conservative approach for a person that's not patient is more difficult. So, you know, it's very true. And we, you know, and the other thing is like proper, like nutraceuticals, make sure they have good pain management, even if it's just icing at home, you know, after. So, but yeah, it's, you know, like I can usually tell right away if it's going to work with a client, you know, like, you know, how dedicated they are. So, but I'm very upfront with, okay, we can try this. And I tell them I want to be respectful of your funds, you know, as well. So, you know, this is what it's going to cost and all of that sort of stuff. So, yeah, I hope that helps.
It does help. And these are the kinds of people that, like, their vibe just isn't very good. So I know it wouldn't work.
Yeah. Yeah. And, you know, they want the quick fix, but I'm like, yeah, the quick
Yeah.
fix would be surgery, like not,
Right.
you know, I could use shockwave on your dog until, like, it's not, like, it's great, but it's not going to cure all these other things, you know, so, which, you know, I'm very like careful with that. And I think that goes back to communication and education of the client. And it's tough sometimes, like, you know, we all work with animals, we get that read and we know. So, yeah. Yeah. Other questions? looking stuff. How many of you are using it with your post-op cruise ships? You're muted, Cindy.
I have a question,
No.
please.
Yes, go ahead. And then Samantha, I'll get to your question too.
My question is about in the initial onset of rehab, dealing with the TTA versus the TPLO in those first month to 6 weeks.
Mhm.
Is your therapy designed differently to protect the surgical area differently, or is it pretty much the same standard?
As opposed to a conservative cruise ship?
Well,
Or-
as the two, like as proposed, is it a TPLO versus a TTA? Does that make any difference in your therapy?
Yeah. So I mean, certainly the structure is a little bit different. I usually feel that I don't want to say be a little bit more aggressive, but the TPLOs will handle a little bit more. So sometimes the TTAs will inflame up more if they're just more susceptible, like overall, with not only with shockwave, but with regular activity and that sort of stuff. So yeah. So approaching that way and looking at it. And of course, too, like post-operatively, like I had a TPLO come in yesterday or the day before, 3 weeks out, and the dog is still non-weight bearing. So like that dog needed I sent it back to the surgeon because I was like, something's not right here. And the owner is a previous client, and she's like, oh yeah, you know how to fix this. I'm like, no, something is probably wrong in there. So, kind of doing that. Samantha, what are your average pulses you tend to direct into the joint space? And that's really a good question. Obviously, it's going to depend upon the size of the dog. And if we take, let's say, a Labrador, I may use a total of anywhere from 2,000 to 4,000 pulses in the stifle. So I may work, again, that medial side and work up to 1,000, looking for responses, spend some more time on the distal hamstrings and then move around. If it's a smaller dog, like my little Brussels is floating in and out here, certainly much lower. And I think, right, there are guidelines, Cindy, that the book
So
has.
we give you guidelines, and they're not, dosing is difficult. I think it's something you have to play with. And Dr. Deb does more pulses, but she uses very low energy. So it's a balance. I have some people, I think it's Lisa Mason, who will do no more than 1,000 pulses, but she tends to go up to an energy of 6 versus an energy of 1. So it's definitely a balance.
Yeah.
And
I think too, I always, especially the initial appointment and the second appointment, will I don't want to say error, but proceed cautiously. So I want to make sure, like my rule of thumb, I want to, on that initial visit, I want to make sure the dog is feeling better. So I don't want to overdo anything. And that goes for modalities, shockwave, or, anything like that. So I always want to be careful, with that. And then, kind of see. So I look at, hopefully he doesn't disconnect me here. I look at, I tell owners I want the dog to be okay. Like they can be tired and maybe a little bit sore 4 to 6 hours after the treatment, but nothing after that. So if the next time they've come in and they said, oh gosh, Boris like couldn't move for 3 days after, well, what did I overdo shockwave? Did I bring too much energy into that joint? What happened? So trying to get a little bit more clear-cut answer about that. So good question, Jennifer. If you want to put any other questions in the the box too, I can answer them. And I think it is like Cindy and I joke, it's kind of like an art, and but you're coupling it, of course, with science. So what works best, for you and what you're most comfortable with. And I like myself and my staff, like with a stifle, I mentioned starting medially and working around, and the same thing with hips. Like I always find the medial aspects of the joint are, I don't want to say neglected, but don't get enough attention. So my protocol is that we start there and move around. Same thing with like elbows, shoulders, that sort of stuff. And even like we had a Great Dane come in today, and the linear head, which I love, like Cindy withheld that from me for like 2 years, and I saw it. I was like,
No.
need that. Well, I don't know, but to put that linear head like down on the distal hamstring area is incredible. So you just like, the dogs just completely relax. And there's definitely this, like you tell owners, like, what are you doing? And owners are like, oh my gosh, you're going to shock them, or like your dog is falling asleep, like your dog is out cold, they love it, especially on that stifle. You hit those distal hamstrings, and it's almost like this release, that they relax right away, and they're feeling so much better. If you you can work some soft tissue work into that too, if you're feeling comfortable, and depending upon the size of the dog and how active they are, getting around and also working that soft tissue area and that sort of stuff. So yeah, the head size, let me see, Samantha. So the question, in terms of head size, do you alternate between heads in a single patient? So definitely. And I think if you look, I mean, certainly the distal hamstrings are a lot thicker than the patella region. So I'll switch heads and maybe change the settings. The distal hamstrings may be able to absorb a higher intensity, while the patella region cannot. So switching heads, nothing says that you have to stay on the same settings or use the same pads for the entire treatment, as long as you're documenting and all of that. But when we look at the soft tissue surrounding, it is very different. So to do that, and look also at, like, for some of the smaller dogs with cruciate disease, and if they have MPLs and all of that going on, looking at the smaller head, whatever the number is, and working around that area and the medial aspect as well, and hitting trigger points as well there. So great question, Samantha. But sometimes it does, like like I've talked to a practitioner, I think in one of our classes, and she's like, well, it's kind of a pain to switch heads. I'm like, yeah, but your treatment is much more effective, so
Yep.
that's awesome, Samantha. Yes, that's what I do too, and line up the heads. And like in my head, I think, okay, this is what I'm going to use, and switch through things. So it's great to do that, and I'm glad you're thinking like that, because you may find that again, like something, you may have 4 Labradors all with cruciate disease, and different things are going to work differently for each of them. So yeah, I'm glad you're doing that. That's awesome. Yes. More questions about cruciate disease, like I have a Labrador breeder who I've now seen 3 of her labs on for, they've had a total of 5 TPLOs. And so she's now doing the DNA through, I'm going to forget, it's late for me, at University of Wisconsin, maybe, to look at the cruciate disease, the DNA aspect. So great that they're doing that for labs and Rotties and some of the other breeds too. So, yeah. You're kind of stealing my thunder here. Say hey.
He's adorable.
He's panicking because everyone's like, whatever. He's watching his dad. So other questions. What are your biggest hurdles with treating the stifle? And let's like also talk about like, yeah, we have cruciate disease, but MPLs, what I love to do with MPLs, and if any of you have had patella luxations for you, you know the outside of your knee or the lateral structures become very tight and restricted. And with the MPLs, so the medial side becomes very restricted. So if I'm treating the right stifle, I like to have the dog lying on its right side in lateral recumbency and work on that medial aspect to, you know, and get in there and then use a smaller head, use the shockwave, then get in there and do a lot of soft tissue work. So we're starting to loosen up the medial structures and then work on the rest of the knee. So I pause with the shockwave after I do my soft tissue and then come back and move around more. So that like works nicely. And we think about loosening up those structures, reducing the inflammation, and then really focusing on that quadricep strength. So we know not all, but a lot of these dogs are little, and it doesn't, you know, take that much to, you know, put in there. So once I'm comfortable with that, I may have the dog standing on an unstable surface. So we're engaging their quads and we're treating at the same time. So kind of sneaking in with the round head and getting in there, and that works great too. And like if you work in a sporting atmosphere, you may be seeing caudal cruciate tears. And so those are like, that seems to be like a hot term lately. I don't know if they truly are, but you know, we're kind of thinking of the reverse of your cranial cruciate. So a lot of times, sorry, he's like just on my computer, on the distal quads and working up loosening that. And we've seen like a few legitimate ones, and I think now more and more are coming in. I'm like, yeah, no, I think we just don't know what is going on. I'm sure everyone is aware of this, and if you have both a shockwave and a laser in your clinic, we've just had in the past month 2 golden retrievers come in. Owners refused radiographs. They were referred in for rehab with a cruciate injury, and I just did not smell well, you know, 7 to 9-year-old golden retrievers and not getting better, worsening, all that sort of stuff. Just be, you know, shockwave is always like, if we're starting, I may not go near the stifle, try to calm down the hamstrings, but both of those turned out to be osteosarcomas. So much caution with that. And those are like, you know, usually within the first visit, I'm like, this is not rehab. This is, you know, I think too, so many of our referrals, everyone's so busy. And it's like, oh yeah, you know, in both cases, the owners had been here previously, and they're like, oh no, we're just going to go see Dr. Deb at Wizard of Paws. We know what this is, but, you know, just to be so careful with that. And, you know, we really want the stifles to be radiographed before we start treating. So important with that. Yeah. Other questions? You guys have to have other questions.
I don't want to monopolize by asking all the questions, but my difficulty at my job is I am the CCRP and I have 2 technicians that have been working with me for many years, but in translating the treatment protocol to them, I am always a little worried that not every
Sure.
nuance is translated to them, if that makes sense.
Right.
So is there a way that you are able to accurately create a treatment protocol that your staff can follow, that you see consistent results between patients?
Yeah, good question. So, I mean, of course, everyone does things a little bit differently. I'm pretty specific in my note taking of what is done. Like, for example, on the medial stifle, these were the settings. There's a total of X amount of whatever, and I use this pad. And so I probably at like too much sometimes just write like everything down, like I switched to this pad at this time, and that sort of stuff. It is tough sometimes, but like the more information the better out there with that. And we do a lot of like, I don't like hover, but like, hey, this is how I do it. And so everyone is kind of trained that way. But it's hard with a new person coming in, or if you're just like, sometimes I'm like, oh my god, light bulb goes off. I'm like, oh, why am with certain conditions, why am I not treating the piriformis area, or that sort of stuff. So then we'll kind of have a powwow and do that. But no, it's a good question, Samantha, because I have a practitioner that was trained somewhere else with a different shockwave unit, so her approach is completely different. I'm like, no, so this is how we're going to do it. Like, pain is not the goal, and all of that. So yeah, no, good question. Keep them coming.
So I try to about that, getting the the doctor and the techs on the same page. I do think especially in the beginning with using the shockwave, if you guys can do the first treatment together until everybody's super familiar. Once they're familiar, I really believe that technicians should have a little bit of a leeway to make changes, because every case the dog's going to come in different as long as they note it. But I do think it's very useful from our point of view as a technician to do the first treatment, with the, with the doctor, and know what they're thinking, because we can visualize better.
Yeah, and I'm sure. I just lost my train of thought for a second too, with like, we're very into like the team approach, with things. So like, oh, you have a minute, like come run in and we're changing this, or that sort of stuff. And I love it. Yeah, very good. So every single detail. I know sometimes like, I'm like, did you read this? Like, do you understand? Like, it's all okay. And I don't want to say I'm a control freak, but like, I like, because we want to see results. And like, if it's done right, like you see such good results quickly. And, then you want to continue to see those and, get them back. So great, Samantha. Other questions? Someone? The kid in the background? So cute.
He's so cute.
Yes. Everyone's quiet.
I know everybody's really quiet tonight. I don't know about you, because it's late, but it's not late on the West Coast.
No.
No. And is that Vicky Wilk in her car somewhere?
Oh.
Looks like
I know. Oh yeah. Those are always good
Yeah, I'm driving.
Yeah, I'm driving.
Sorry, I'm heading back from Iowa, so.
Gotcha.
Can I comment on the non-surgical question that Katie had?
Yes, absolutely.
Because I just, I do a lot of cruciates, but we do a lot of rehab and non-surgical too. So I just I always put it to people, The only thing we're losing is time. I don't think about the money.
Mhm.
We're just losing time, and maybe we'll avoid surgery. That's the way I phrase it with people. If their goal is to avoid surgery, why not try it, right? Because all you're going to lose is some time.
Right.
And if you don't make progress with it, like you said, Deb, then surgery is the next step. And then they're more committed to doing surgery because they know they've exhausted those other options.
Right.
That's not kind of how I feel about it. And they're getting in better shape to recover better from surgery. So it's not that it's wasted. They're getting in better shape so that when they do go through surgery, and then the owners are kind of used to restricting activity already. So they're kind of on par. So that's kind of how I approach it. Yeah, they may ultimately get there, but maybe you got a shot that they won't, and they'll be better candidates.
Yeah. And it's, and that's a very good point too, because, talking to owners that, hopefully we're gaining strength, and if everything is going well, all of that sort of stuff. And it's not, because certainly the dogs that have had rehab prior to a cruciate surgery, I mean, just catch on so much faster. I feel like they rehab, to their ultimate goal a lot faster as well. So yeah. Well, thank you, Vicki. Great with that. Okay, quiet group. Other questions?
What about iliopsoas? Do you want to talk about that? Because I see a lot of dogs that come in for ACL tears and they're actually iliopsoas.
Yeah, and very good point. So we see a lot, and I feel like vice versa. I think that there's a lot. I always ask myself, okay, is this a primary iliopsoas injury, or are they compensating, trying to hold on to stabilize that cruciate? So with those, my kind of protocol, what I've been doing, unless it's a specific, like we know that this was a sports related injury, this happened, and that I'll add in the stifle. So I'm treating the lumbar component, the iliopsoas itself, and then the stifle as well. Because I've seen both, like that. Yeah, they're in for, they have a confirmed cruciate tear, but their iliopsoas is so restricted because they haven't been engaging in hip extension or working their lumbar area. And then I've had others where they come in, iliopsoas, and it's actually a stifle injury all along, but that's there too. So I do like to, certainly I always say it's not just a stifle. We're looking, my staff, we go through what's the secondary issue, what's the tertiary issue, and make sure we incorporate all of that and work on all of that. So it's a really good point with that, because even post-surgical, that iliopsoas area is going to be restricted. It's going to have issues. So, we have to add in hip extension treatment. And again, there's nothing wrong with working. I love to use the shockwave on the iliopsoas area. I find it so effective, to hit the insertion and the lumbar component. So thank you for bringing that up, Vicki.
So one thing I want to kind of stress about the iliopsoas at the insertion. I've had conversations with a vet who had, a dog shockwave did another place with another unit, and when she went to ultrasound, that insertion, it was blown to pieces with inflammation. So I always try to make sure that people are really careful about the amount of energy and that you put at that insertion.
Yeah.
They were using an electrohydraulic with a much bigger area, and then with the much bigger area, you're hitting a ton of bone. So it was definitely a much stronger treatment, but it was super evident on the ultrasound. So that made me kind of say, whenever I start somebody on an iliopsoas protocol, we know they're sensitive there because we touch them and they're sensitive.
Right.
But we can create too much. You don't want to create trauma at that site. You just want a
Sure.
tiny bit of energy.
Yeah,
you know,
and
so-
definitely going back to if it's painful, you know, I love the animals are giving us feedback and, giving us everything while we're treating. So good, very
Don't
good
hold them
point,
down.
Cindy. Yeah. Yeah. Don't hold them down. Don't sit on them. All of that sort of stuff. So, yeah. Anything else?
Super quiet group. So
I
where I know where Rachel's from. I know Dr. Babette's on. Jennifer, Dr. Eckenrode. Where's Kira from? I don't recognize
I
that.
I work with Dr. Rachel.
Okay, you're both there together. Good. Good. And how are things going out there?
I think they're going pretty good.
They're going good?
I really enjoy the use of the piezo a lot. So
Good, good, good.
Um,
And Dr. Babette, I owe you a contact in New York City. I made a note. I will bug my New York City people for you. I am sorry.
I'm sorry I came in late. I do have a question. Is anybody doing any of the auxiliary acupuncture points, reference points, when they're taking care of the knee and the surrounding tissue?
So I definitely am. I mean, with acupressure and treating that. So I think that's definitely, when you look at the referral sources of pain and all of that, I think that's a wonderful idea. And, it's very effective. And you may not do it, the entire length of the animal's treatment because you're getting them feeling better and all of that, but absolutely.
Okay, what I was referring to is specifically at the acupuncture reference points.
I'm
If
sorry.
if we're doing shockwave.
Yes. So maybe Cindy can answer that better.
I do have some people who do the actual acupuncture points for sure. It's mechanical transduction, so it does create the same energy flow for sure. Dr. Bonnie does it some for sure. Definitely useful. It depends on, I think it just depends on your case and what the pets are responding to, but I do know that we talk about it in the acupuncture course for CRI some, and they follow the meridians and hit some of those areas also. I don't know the specific ones for the knee because I'm not that well trained in acupuncture. I'm learning slowly.
No, but definitely, I mean, the benefits, all of that are good. And I put my email address and also on our Instagram page for the clinic, we have a ton of cases and stuff up there. Samantha, yeah, I can answer your question about bicipital tenosynovitis, and it's a tough one. I think that's definitely one that it takes at least 2 to 3 treatments to see a change. Typically, again, use lower energy in there because the area is fairly inflamed. And part of my protocol is not only treating the biceps, but the rest of the shoulder capsule. And then I also go up to C5 to C6 and treat the cervical component also. So many of the bicipital tenosynovitis, I'm finding that the infraspinatus is also compensating so much. So I focus on that too. Again, fairly low energy, with that, and then follow it up with range of motion stretching. So in the pain-free zone, and if we can, a little bit of eccentric activity, of course, weight-bearing position just to start to loosen up region. And if you're familiar with cross friction massage or deep friction massage, I'll deep friction after I do the shockwave to help with the realignment of the fibers. So they're always tough cases.
Well, I comment on the bicipital tendonitis because in the cadaver lab at IVAPM, we actually were looking at how close the supra is, and when that gets inflamed, it just squishes the biceps. And in our shoulder data that we're processing for a paper with Dr. Tomlinson, they're finding most of the time it's both tendons involved when you actually do ultrasound. So I thought that was interesting. But it's a hard structure, hard area for sure. But it was kind of fun when we were digging through the cadavers and they're like, but look at how close they are. They it smushes it. So
I feel like, there's so much involvement there. So yeah, definitely. Yeah. Yeah. Any other questions? And I'm always like, I don't mind if you send an email answering questions, and I'm always like open to things or like listening to like cool stuff, and love to bounce ideas off of each other. So please feel free to always reach out. If I don't know, I'm going to say, hey, Cindy, which I don't know.
And if I don't know, I might send you to somebody else, but
it's always good.
But everybody's that is been a very good thing. Of all of our users have been really good about sharing what's worked, the pros and cons, and that's how we learn. So I appreciate Dr. Deb's time so late on a whatever night it is, and we're heading to, she's teaching manual therapy tomorrow, and I will get there eventually. And but we appreciate everybody's time, and as a company, Elevation is just really glad to have good people to support us. We're small, we're tiny. I've heard some crazy stories out there in the last I would say week of doing demos, and we really want to give you guys the science and the background to do the best you can do. And I hope we're doing that, but if we're not, let us know. And if anybody else has cases or wants to participate in some of our group activities, reach out to me. We're always looking for it. And I appreciate everybody's time. And it's wine time. It's dinner time and wine time. But thank you, everybody. Any final questions, or let Deb get to the next part of her night?
Sleep. Thank you, everyone. Yes, I know. Thank you so much. Please reach out with questions and have a great evening.
Thanks,
And
guys.
I'll see you tomorrow.
We'll see ya. Have a good night.
You too. Bye-bye.
Thank you.
Bye,
Bye.
guys.